Welcome to the Radiographics Podcast. I'm Wendy Gibbs. This week, Dr. Frederick is summarizing a paper on chest wall pathology, and this will be of great interest to radiology residents as it contains a large volume of material very relevant for the core exam. And it's important for the rest of us because most images we read do somehow cover that important part of the body. Actually, I had a chest wall mass on a very last image of my CT neck study the other night, and this summary really helped me out. And to stay with the focus on chest, I'm going to talk a bit about imaging of COVID. Now, many, including myself, think that COVID imaging has been covered quite enough by now. But recently, I've started to see more cases with lung findings that I think are COVID than I ever saw previously. This is on my spine and neck studies, which all include the lungs, unfortunately. I wanted to brush up on the imaging findings of COVID, as well as the changes we see in patients who have recovered from COVID. All right, so let's start with Dr. Frederick's article.
Diagnostic and imaging approaches to chest wall lesions. This article has a lot of meat that is relevant for those R3s out there who will be taking boards this year. It was also tougher to summarize than usual because every sentence seemed valuable. Benign and malignant chest wall lesions account for 5% of all thoracic tumors. Making the diagnosis on the basis of imaging findings alone is challenging, as there is significant overlap of imaging appearances among the different lesions. While imaging may not lead to a specific diagnosis, it can help narrow the differential diagnosis to further direct diagnostic workup, management, and treatment. Imaging allows the classification of chest wall lesions based on their attenuation or signal intensity, which may be that of fat, calcification and ossification, fluid, or soft tissue. Cross-sectional imaging is the best way to further evaluate chest wall lesions. CT and MRI enable assessment of the location, composition, and enhancement characteristics of suspicious and incidental lesions. CT is superior to MRI in depicting calcification and enables better assessment of bones. MRI provides greater contrast resolution of soft tissue lesions. MRI is the modality of choice for evaluating pleural, mediastinal, or organ invasion. Moreover, MRI enables better tissue characterization and better assessment of nerve and vessel involvement. Often, especially with more complex lesions, both CT and MRI are performed. Let's start with fat-containing lesions, the most common of which is the lipoma. Lipomas have the attenuation and signal intensity of normal subcutaneous fat on CT and MRI. Fat-suppressed MRI sequences can be used to distinguish lipomas from other lesions or structures that may demonstrate similar signal intensity on a given non-fat-suppressed MR image. Lipomas are generally homogeneous without nodular enhancement, but they may contain thin enhancing septa that are less than 2 mm in thickness or calcification in 1/3 of cases. Intramuscular lipomas are a potential pitfall, as these non-encapsulated lesions can occasionally mimic liposarcomas, demonstrating an infiltrative and striated appearance owing to intermingled muscle fibers. Spindle cell lipomas are less common fat-containing lesions that occur in the subcutaneous fat of the neck and shoulder in men older than 45 years. In these fat-containing enhancing heterogeneous tumors, the spindle cells account for the non-fatty areas. At imaging, a spindle cell lipoma usually manifests as a well-defined fat-containing lesion with areas of enhancement. These lesions are often resected as their appearance is similar to that of low-grade liposarcomas at imaging. Fat necrosis can be seen in the subcutaneous tissue of the chest wall, and it may lead to confusion, as most patients with fat necrosis do not recall a traumatic incident. On MRI, fat necrosis appears as a globular lesion containing a fatty core and surrounded by a hypointense rim. Calcification and fat stranding are sometimes seen. These lesions are often confused with malignant neoplasms such as liposarcoma owing to their imaging appearance and FDG uptake. Decreasing size at follow-up imaging can be a helpful clue to suggest this diagnosis. After undifferentiated pleomorphic sarcoma, liposarcoma is the most common malignant soft tissue chest wall tumor. The various types include well-differentiated, dedifferentiated, myxoid, pleomorphic, and mixed. The more differentiated the tumor, the more fat it contains and the less aggressive it is. Conversely, the more undifferentiated tumors have less or sometimes no fat and are more aggressive. The well-differentiated subtype is the most common, accounting for approximately half of liposarcomas. On images, these tumors contain a large amount of fat, which account for over half of the tumor volume. It is worth noting that differentiated liposarcomas have an appearance similar to that of lipomas in about 10% of cases. MRI findings that help well-differentiated liposarcoma from lipoma include septa that are greater than 2 millimeters in thickness, nodular soft tissue areas, large size greater than 10 centimeters, and fat encompassing less than 75% of the tumor. A well-differentiated liposarcoma showing interval development of an enhancing T2 hyperintense area suggests a dedifferentiated liposarcoma. Myxoid liposarcomas represent approximately 20 to 50% of liposarcomas and comprise less than 25% fat. Myxoid areas usually have high water content, manifesting as T2 hyperintensity and as hypoattenuation on CT images. If percutaneous biopsy is needed, the non-adipose components should be targeted. Now let's discuss calcified and ossified lesions of the chest wall. Calcified and ossified lesions can occur in the soft tissues or arise from bone. Most primary osseous tumors of the chest wall arise from the ribs. First, we'll go over the benign lesions. Fibrous dysplasia occurs secondary to a developmental anomaly in which normal marrow and bone are replaced by fibrous stroma. Usually an incidental finding, fibrous dysplasia can result in a pathologic fracture or rarely malignant degeneration. The ribs are a common location, and imaging demonstrates an intramedullary, expansile, long segment, well-defined lesion. These lesions may demonstrate endosteal scalloping and cortical thinning. However, the cortex remains intact. These lesions show varying degrees of hazy ground glass matrix. However, they may appear nearly entirely lucent or sclerotic, depending on the degree of fibrous component. At MRI, fibrous dysplasia shows variable signal characteristics and enhancement, depending on its histologic composition. Osteochondromas are common osseous lesions that occur secondary to aberrant growth of normal bone tissue, most commonly at the costochondral junction. Corticomedullary continuity with the parent bone is diagnostic. MRI may show a characteristic T2 hyperintense cartilaginous cap. Patients with hereditary multiple exostoses have up to a 5% lifetime risk of malignant degeneration, most commonly into chondrosarcoma. These patients may present with pain associated with the osteochondroma. At imaging, malignant degeneration should be suspected if the cartilaginous cap increases in thickness to greater than 3 millimeters, or if irregular calcifications or osseous erosions develop. Tumoral calcinosis refers to soft tissue calcification that occurs in the setting of end-stage renal disease or chronic inflammatory conditions. These calcifications are typically found adjacent to joints and can be symmetric. Other clues at chest imaging can help suggest the diagnosis, including atrophic kidneys in the partially imaged upper abdomen, subchondral bone resorption at the sternoclavicular joints, diffuse vascular calcifications, and increased bone density. Myositis ossificans is a specific type of heterotopic ossification that occurs in muscle after trauma. In the first 1 to 2 months, myositis ossificans has the appearance of a soft tissue mass with floccular density. After maturation, usually by 2 months, the characteristic imaging finding of a soft tissue lesion with peripheral calcification is seen. This peripheral calcification can be useful in distinguishing myositis ossificans from parosteal osteosarcomas, which tend to have central calcification. Early myositis ossificans can enhance and be mistaken for sarcoma. In this scenario, follow-up imaging can be performed for a more definitive diagnosis. It's best not to biopsy these lesions because they can be mistaken for malignancy at histopathologic analysis. Connective tissue disease, such as scleroderma and dermatomyositis and polymyositis, also can lead to soft tissue calcification that is more punctate and dense than tumoral calcinosis. In scleroderma, these areas of dystrophic calcification are more commonly seen in the hands, but also occur in the chest wall. Other clues to scleroderma at chest imaging include a dilated esophagus and interstitial lung disease with a nonspecific interstitial pneumonia pattern. Dermatomyositis and polymyositis classically cause calcification of the fascia. Patients with dermatomyositis also develop cutaneous calcification. The calcification occurs as a healing response to recurrent episodes of necrosis. These patients often develop connective tissue disease-associated interstitial lung disease, more commonly with a nonspecific interstitial pneumonia pattern. Chondrosarcoma is the most common primary malignant neoplasm of the osseous chest wall. The most common location is at the costochondral junction. A chondroid matrix, including arcs and rings and stippled appearance, seen on radiographs and CT images, is suggestive of chondrosarcoma. A more osseous-appearing matrix that manifests as dense, cloudy, or ivory-like is suggestive of osteosarcoma. In addition, chondrosarcoma tends to have more peripheral calcification, whereas osteosarcoma has more central ossification. On T2-weighted MRI, chondrosarcomas are usually hyperintense owing to the presence of a cartilaginous matrix with high water content. Now let's go over soft tissue lesions of the chest wall. Elastofibroma dorsi lesions are benign and classically located between the serratus anterior and latissimus dorsi, deep to the inferior aspect of the scapula. This lesion results from the accumulation of fibrotic tissue with elastic fibers. Elastofibromas are much more common in women and can occur bilaterally in up to 2/3 of cases. The appearance of elastofibroma dorsi on CT and MRI is pathognomonic, especially when the lesions are bilateral, with attenuation and texture similar to those of skeletal muscle. It typically has linear areas of fat within the tumor, which are sometimes termed the lasagna sign because of the layering appearance. Elastofibroma dorsi is considered a do not touch lesion, for which the diagnosis can be confidently made with imaging alone, especially when the lesions are bilateral, with no need for biopsy or resection unless the patient is symptomatic. The most common nerve sheath tumors are schwannomas, followed by neurofibromas. In the chest wall, these tumors usually arise from the intercostal nerves that course beneath the ribs and can extend into and widen the neural foramina. Neurofibromas and schwannomas occur in the same location and have overlapping findings. A few MRI findings can favor one diagnosis over the other. Approximately 50 to 70% of neurofibromas may have a target sign on T2-weighted images with a hypo-intense center surrounded by a hyper-intense periphery. The central portion corresponds to the fibrovascular tissue that also enhances, and the peripheral tissue corresponds to myxoid tissue. The fascicular sign on T2-weighted images, characterized by rings of hypo-intense areas, favors a schwannoma. Larger schwannomas can develop areas of hemorrhage, necrosis, cyst formation, and/or calcification, which should not raise suspicion for malignant transformation. Malignant peripheral nerve sheath tumors are important to identify in patients with neurofibromatosis type 1 because they are at increased risk for these tumors. Imaging findings that favor malignant peripheral nerve sheath tumor include rapid growth, size larger than 5 centimeters, interval loss of the target or fascicular sign, infiltration into the surrounding soft tissues, adjacent osseous destruction, and evidence of distant metastasis. Aggressive fibromatosis, also known as desmoid tumor, consists of well-differentiated fibroblasts that develop from the connective tissues of the muscle, fascia, or scar from trauma or surgery. On images, they manifest as ill-defined and infiltrative masses. With aggressive fibromatosis, the mass is generally heterogeneous on CT images, but can have the same attenuation as muscle. In these cases, the clue that a desmoid tumor is present is focal or asymmetric enlargement of a single muscle. At MRI, desmoid tumors are classically iso-intense to muscle on T1-weighted images and have intermediate or high signal intensity on T2-weighted images. While desmoid tumors usually are locally aggressive, they do not metastasize, and the presence of distant metastasis should suggest other neoplasms such as sarcoma. Other soft tissue malignancies involving the chest wall include sarcomas, myeloma, lymphoma, and metastases. Finally, let's cover fluid lesions. Lymphatic malformations occur most commonly in the neck and axillary regions and consist of dilated lymphatic vessels. They usually have a cystic appearance and after contrast administration may show thin peripheral and septal enhancement. On more delayed contrast-enhanced MR images, these lesions may show gradual increased enhancement owing to third spacing of contrast. Lymphatic malformations are often quite infiltrative, extending through multiple thoracic compartments. There may be associated lymphatic edema in the lungs or chylous pleural effusions if the lesion is extensive. Aneurysmal bone cysts uncommonly occur in the chest wall. The most common location is the posterior elements of the spine, and less commonly the posterior ribs. An aneurysmal bone cyst may occur as a primary tumor or as a result of a secondary primary bone tumor. On MRI, these lesions are multiseptated and usually centered within the rib, with a well-defined hypointense rim. Fluid levels are highly suggestive of ABCs and occur as a result of hemorrhage into the cystic spaces. Fluid levels are not pathognomonic and can occur with other tumors, such as telangiectatic osteosarcoma and giant cell tumors with secondary aneurysmal bone cyst change. Alright, let's recap the teaching points from this article. A well-differentiated liposarcoma showing interval development of a T2 hyperintense area that enhances after contrast administration suggests a dedifferentiated liposarcoma. Corticomedullary continuity with the parent bone is diagnostic of osteochondroma. Elastofibroma dorsi typically has linear areas of fat within the tumor, which are sometimes called the lasagna sign because of the layering appearance. With aggressive fibromatosis, the mass is generally heterogeneous on CT images, but can have the same attenuation as muscle. In these cases, the clue that a desmoid tumor is present is focal or asymmetric enlargement of a single muscle.
Wow, so many things to keep in mind, but that was a great summary. Okay, now my turn. As I said, despite Omicron purportedly affecting the lungs less than Delta, it seems like I've been seeing more and more lung abnormalities in people with or who've had COVID. When I wanted to brush up on this, I found a great paper called Chest CT and COVID, What the Radiologist Needs to Know. And this was by Cui and Cui in the October 2020 Radiographics issue. So I highly recommend this. We know that the acute course of COVID is variable and ranges from asymptomatic infection to fulminant respiratory failure. For patients with COVID and lung involvement, chest CT in the first 5 days after symptoms start most commonly show ground glass opacities, or mixed ground glass opacities and consolidation in a peripheral and subpleural distribution. The peak in acute CT findings is around day 10. The opacities may be nodular and peribronchovascular distribution. Typically, there are not pleural effusions and there's no lymphadenopathy. Those with lesions initially in a unilateral distribution quickly evolve into a bilateral involvement pattern. A study evaluating early radiologic features of COVID found that a dilated pulmonary artery and air bronchograms were seen in the majority of patients. The dilated vessel, potentially related to thrombosis, increased blood flow, or small emboli, could be a marker of the coagulopathy seen with COVID. A quarter of patients had a halo sign, composed of ground glass opacity around a solid nodule. Although a halo sign has often been associated with vascular etiology, it may also represent organizing pneumonia. Additionally, many have reported a reverse halo appearance, in which soft tissue density surrounds more central ground glass opacity. In some patients, these changes will evolve to include mild and focal reticular abnormalities by week 2 and an increase in consolidation by week 3. Patients recovering from COVID can have persistent symptoms and CT abnormalities of variable severity. At 3 months after infection, a subset of patients will have ground glass opacity and subpleural bands with concomitant pulmonary function abnormalities. At 6 months after acute infection, some patients develop imaging findings suggesting fibrosis, such as reticulation with or without parenchymal distortion. The etiology of lung disease after COVID may be sequela of prolonged mechanical ventilation, COVID-induced acute respiratory distress syndrome, or direct injury from the virus. Pulmonary fibrosis is known to develop in a subset of patients with ARDS, and the duration of acute respiratory failure in ARDS has been independently implicated in the development of pulmonary fibrosis. In a subset of survivors of ARDS, persistent fibrotic changes often correlate with restricted physiology on pulmonary function tests, and a worse health and pulmonary-related quality of life up to 2 years after infection. Ventilator-induced lung injury, a direct injury to the alveoli that leads to pulmonary interstitial edema, hyaline membrane formation, and alveolar collapse, is commonly seen in patients with ARDS and can directly contribute to the development of pulmonary fibrosis. It may have a role in the development of lung disease after COVID-19, given the longer duration of mechanical ventilation and higher incidence of barotrauma seen in patients with COVID ARDS compared with non-COVID ARDS. Autopsy studies of patients dying from COVID show evidence of ARDS on biopsy, as well as COVID in pneumocytes, fibroblast proliferation, and microscopic honeycombing. Viruses are known to influence responses to other fibrotic stimuli and in select cases cause fibrosis on their own. The relative contributions of these factors to lung disease after COVID are currently unknown. In a small subset of patients, the etiology of lung disease after COVID appears to be an exacerbation of underlying interstitial lung disease, a known complication in patients with fibrotic lung disease after lung infection. So in conclusion, the most common abnormalities we're going to see are ground glass opacities, parenchymal bands, reticular abnormalities, traction bronchiectasis, and mosaic attenuation. The prevalence of CT abnormalities varies depending on the severity of initial lung involvement and the time interval since infection. Longitudinal studies suggest that ground glass opacities can be replaced with fibrotic appearing abnormalities, and abnormalities may persist in patients with known risk factors. And finally, the long-term impact of CT findings on respiratory symptoms, pulmonary function, or quality of life is still unknown. All right, that's it for this week's podcast. Take a look at these articles and their beautiful images on the website, and you can also find related resources. And follow us on Twitter to see more related cases.